So good evening all. Shall we start or we should wait for 5 more minutes? Good evening, Dr. Beena. Good evening, my dear. Any of you have any questions? Still we are waiting for 5 more minutes for people to join. The people who are new to me, Dr. Aditi, Dr. Angela, Dr. Shiva Sankari, do you have any questions to me? Do you have any specific concern you want to listen from me today? Dr. Sanya, Dr. Gopi. Salam, Dr. Shazia. Nice to have you here. Do you all have read this guideline already, this new GTG of antenatal corticosteroid? The good thing is it is very small. Good evening, Dr. Aditi. The good thing is it is very small, but the bad thing is when you read it, you think that you have not learned anything new or you are already knowing everything. So when I first time read this GTG, I thought, did they really made new points? But then when I started putting it point wise to teach, I get to know that yes, there is some small differences, very close differences, which we might miss if we will not read it carefully. Though it's a very small one, but it is very useful for exam because definitely antenatal corticosteroid questions are always there in exam and it will be there in the exam this time. The thing is, because it is a new guideline, definitely the questions will be from the new guideline, specifically the new points they have given, which is different from the previous points. So especially we have to focus on that points, that what is different, because always they will ask a different thing, the new concept, that did you get that new concept from the guideline or not, right? Hello, Dr. Khushbu. How are you?
Hello, ma'am. Yes, ma'am. I am fine. Hello.
Nice to have you here, my dear.
Thank you, ma'am.
Okay, so I think we should start now.
Yes, ma'am.
Yes, so let's start. So today's agenda of ours is, this is a webinar, and as well as we are going to see, for especially my friends, my near and dears who couldn't make it this time, what we are going to do differently this time in our next attempt. So we will be focusing on that part, and then we will be covering the GTG and the related talks of antenatal steroids. Whenever a new GTG comes, the talk become more important related to that. So we have one 2021 talk and one 2019 talk. So I will be covering both of that so that you get everything about the steroid in one page, so that it will be in your brain so much inculcated that in exam you will not have any difficulty regarding this. I hope you all know me. You all know me by Telegram, by YouTube, by Facebook. So I welcome you all on behalf of aimmrcog today. I am the course director and chief mentor at aimmrcog. So we will start the session now. So what happened? What happened actually? Today's agenda is what went wrong. Basically for the students who could not make it this time. Maybe it is their first attempt or maybe it was their repeated attempt. This is not a surprise, because MRCOG is the second most toughest exam of the world. We all know. And we are not simply sitting and reading for it. We are trying to accommodate this study with all the challenges we are already facing, our difficult work atmosphere, our family commitment, many other things are running in our mind, and we are reading. So definitely it becomes further more difficult for us. But whenever we are trying anything, whenever we are trying to do anything, we try to succeed, right? That is why we are going ahead, thinking that we should succeed and we will try hard and we will try hard. So whenever we couldn't succeed, we should go back and think and judge ourselves that what went wrong, right? And sometimes we will find out that, yes, this is what I didn't do. Maybe I can do this, or this is what I should have done. This is what we keep thinking. But sometimes we don't know what went wrong. Means we were fully prepared. We gave our 100%. We gave the exam well with confidence. Everything went off well. and the result has come shocking as a negative outcome, then it is just not your day. Sometimes our luck doesn't favor us. So the main problem is we get disheartened by failure, right? Anybody will get that. Even any student, anything, even small day-to-day affair, if we don't succeed for anything, we get disheartened. So this is what we have to remove from our mind, because this is a difficult exam. We are not giving it because this is going to change anything. Maybe sometimes we are just giving it for our knowledge, for our satisfaction, to get an international degree, which might not change our life at all. But you will be a more confident, and evidence-based practicing medical professional. So some people goal is that. So why not be easy, little easy on ourselves, and why not we do simply some things which we can do differently. So let us make some strategy of how to do different and what to do different. So first of all, we have to find out what went wrong so that we can rectify that. And then we will decide what we will do different this time. So this is very important for us to understand both of these points. Then we will be having the discussion of GTG and talks, and then we will be having the SPA session, because this is a new GTG. Definitely we don't have questions on this in books. That's why I have taken the question from MMRCOG question bank. So we shouldn't be scared. We already must have come out of that trauma already. The result is more than 10 days out. So we are now ready with more confidence, more stronger than before, to learn from our failure and try again. The most important aspect of it is, do I need help? Do I need help? This you have to understand well before rather than at the last minute. Because if you need help, you should take it earlier rather than late. Take help from your friend, take help from your colleague, take help from the group, take help from the mentor, anybody. Even free groups are there, even courses are there. Whatever way you need, whatever way you feel is good for you, you have to decide. But if you need help, then earlier is better. Don't wait for the crash courses, don't wait for 2-3 days brush up. This all is not going to work. So we have to decide it, and we have to do things accordingly. So I did, the AIMMRCOG team has done a survey on what went wrong from all the students. And this is what the answers we got. I didn't prepare enough, so I have to work harder. So obviously, if you do a shallow study, if you don't take the enough benefits of all the material, everything you have done, you couldn't revise at the end, you didn't have enough time, you will think, I'm a busy practitioner, I don't have time, I will not solve question, I will not do this, I will not do that. But ultimately, it's a norm-based exam. So you have to be at par with others who are might be simply sitting and preparing for this exam. So you have to understand that you have to push harder and harder. You have to mobilize more time, and you have to give your 100%. You shouldn't have anything at the exam, at the end of exam left. You should feel I have done 100% and I couldn't have done more than this. So that level of preparation we need for this difficult exam. Some student told that there was insufficient time of study. Yes, we are doing the jobs, we are having family, we have other things, we have other commitment. But if we are committed to the exam, we should make our part shorter rather than longer. Because you cannot keep your zeal and enthusiasm for longer years and years and years, right? So every 6 months the exam is there. Supposedly you cannot finish it in 1 attempt, 2 attempt, 3 attempt, then already it is 1.5 years. And then you have third part also. Sometimes that also needs more effort. So definitely it's a difficult thing. I can understand that. But the only thing I expect from a student is you give your 100%. And don't be shy in taking help from your colleagues, from anybody. Don't think that I'm able to do it. If I can, I will try again. This is all lengthening your success curve. Definitely you will succeed one day. If you are committed, you will succeed. But your journey will be long. Your journey might not be that pleasant, because sometimes the failure keeps stuck in your mind. So that's why we have to be very, very particular about our preparation. Some students told that EMQs were very close, need more practice, couldn't focus at the end because of busy duties. Yes, sometimes this is also a reason, but you have to understand that every revision you do should be shorter than the previous one. By the time you reach till your exam, before 1 month, you should be confident almost about everything. Only you have to brush up. EMQs are always very close options until unless you have a thorough study, until unless you have a thorough concept, difficult to clear the EMQ. So most of the time when the student says that we couldn't clear the EMQs, you have to understand that your concept is yet not clear. If you are passing all the SBAs but EMQ is not passing, you're passing SBA in both the paper means you are intelligent, you are smart, your memory is good, but your concept still is not fully clear. That's why the EMQs are not coming correct. So please be vigilant about your outcome and study. The other important aspect is the easy things. Never ignore the easy things, because easy things, smaller modules are always scoring. As I always tell, smaller modules are more scoring. So you should have a good hold on the smaller module. You should have a good hold on EMQ. So you have to do more EMQ practice. Daily EMQ practice, you can do the free practice in the free group. It is not like you need courses always. It is only you need more effort. If it didn't go as you expected, you need to do more effort. You need to put more effort on your weaknesses. Some told that the strategy was not good. I couldn't follow the schedule. Schedule following is something which has to be done because there is no other go. You have to take one day at a time. You have to finish your schedule of that day. Because some week you're busy, some week you're free, but you should finish your schedule. If you cannot finish your daily schedule, you have 24 hours duty, then you have to finish it next day or prior day, like that. But you have to follow your schedule. And if some backlog is there, finish it in weekend. But you cannot pile it up. So following the schedule is very, very important. And as I told you, EMQs are very, very important because most of the students, if they are prepared enough, they will pass SB. But if they are not clearing the EMQs, means they need more EMQ practice as well as they need more concept clearing. Practice, practice, and practice. So this is what our survey told. So there are some myths and some fact I want to clear today, because earlier I used to think, even I was not clear about this myth actually. Earlier I used to think that people who got near miss, like people who got 56, 58, 59% and the passing mark is so close, I used to think that, oh, so good that you have even not, and the student will say me that, madam, I couldn't prepare fully. Even I finished half of the syllabus, or even I didn't do enough of EMQs. I didn't do this, I didn't do that, but exam was okay. And the final outcome is near miss. So I feel, oh God, it is so good. If you have not finished and it is so good, next time surely you will make it. But then I listen the stories. I listen the stories where students are always having near miss, even for 2-3 times. So what went wrong? I thought there is only a 4-5% of gap, but actually it is not that. It is like today the questions was more about contraception. You are good at it. You scored 59%. Next time they will give you more question of CTG. You are weak at it and you are good at others. You got again 59%. Next time they will give you urogynecology more because they are smarter than us, right? RCOG is smarter than us. That's why even we have the recall, even we solve that, even sometimes we are not able to solve that in spite of having that. And even that we get in the exam same to same. So there are some things they are made like that, even in spite of knowing we cannot solve. So definitely they are smarter than us, and definitely every time the difficulty of paper is accordingly. They want to see that you are thorough with each and every aspect. They will not allow you to pass till you are thorough in each and every curriculum, each and every module. So if you have a near miss, don't think that I should just try a little more and I will pass. Nothing like that. That signifies that your preparation is not enough. This is what the message you should got, rather than thinking that this is a near miss, so next time I'm sure. Don't think like that. Giving exam again and again is traumatic without preparation. So don't do that. Don't do that mistake. Give your 100%. Make your concept more clear. If you have read last time 50% and now only 50% left, that is good enough. That means the remaining 50% you should cover. If you cover 100% of syllabus, you will remember 90%, right? We are not computer to remember 100%. If we are thinking we are covering 100%, actually we are covering 90% only. So we will remember 80%, suppose, in exam. Now you're remembering 80%. In exam pressure, you will be performing well only for 70%. So you will score 70% and you are sure short pass. But if you prepare only 60 to 70%, then definitely you are a human being. So you are leaving it borderline, you are leaving it to luck, you are leaving it to by chance. So we don't know what will be the outcome. So how many times we will leave it to chance? We shouldn't leave it to chance. We shouldn't leave any stone unturned. This is an exam which needs full-hearted preparation. You cannot succeed this exam with shallow preparation until unless your luck so overseed your hard work. So hard work and smart work both are equally important, but never ever think that half study is going to be sufficient for this exam. So near misses are really dangerous. That signify you are smarter, you have more memory, you are intelligent, you are good. But still you have to understand you are not good enough means your effort was not correct. You have to change your strategy and you have to be more serious about the exam. The other myth is, I will not read talk. Talk are difficult. I cannot remember it. It is too much. Yes, it is too much. But nobody is telling you to read full talk. Nobody is telling you to read every volume, everything, word to word, page to page. No. You only have to read 2, 3 articles. Just give it a read. As I always tell, talk is to supplement your GTG knowledge. It is not to make it difficult, but to make it easier. So only you have to read the limited talks. Only you have to make the limited summaries. It is not difficult. If you can prioritize properly and you can do a smart study for the talk, it is not difficult, but it will help you only in enhancing your knowledge as well as succeeding the exam easily. The other important thing is question solving. I don't have enough time to solve questions. This is what every student thinks. But you are comparing with the students who are solving question daily. If you don't solve question, you don't know how the guideline lines will be formatted in the question. Once you read the question, you are clueless. EMQ options are so close that if you don't practice that, even you will not think in remote of your mind that this could be so close that I will get confused. Once you read in the exam the simple EMQs, you get confused. If you practice, you will not get that confusion. So question solving, talk reading, GTG, definitely we know that GTG nice. Without that, nobody go in the exam. So guideline reading, making notes, talk reading, making notes, and question solving, all these are equally important for the exam. And definitely you have to give your maximum effort for this difficult exam. Someone out there, someone is working harder than you. So take this as an inspiration and try harder for your own self. Now, winners don't do things differently, do different things. They do things differently, right? So we agree for this that we should do something differently if this time we couldn't succeed. Even now, if you ask me, even now, sometimes I get sleepless nights just to think how to motivate the students, how to troubleshoot their problems, what to do, how to do. Because I'm passionate about teaching. I'm passionate about how to become a better version of myself every day. So this is what is in my mind. When I was preparing, I will peacefully sleep because every day I will follow my schedule, I will do my question practice and I will sleep. But now, because things are not in my hand, I have to motivate others. So I have to think more how others think, what could be beneficial for them. So I have to do things differently according to the student's need every other day to become a better version of myself. So this is how you have to think what you can do differently and how you can become better version of yourself every other day. Little effort every day, believe me, give a great result and great achievement. So little effort every day, one day at a time is what you have to take. Now, so what strategy we will take, what we will do, what was it, how to make it work. So we should have a new strategy. So as I told you, don't take it lightly. Don't think that this time you have a near miss, the next time you are sure shot. No. Next time the level of difficulty will be different. The more you read, the more confusion comes. The syllabus is vast, so you have to do it in organized way. Read properly, prioritize properly, make notes properly, revise properly. Every time the next revision should be shorter than the previous one. Shallow preparation is not going to work, so we have to be thorough. This will not only help us in exam, but also it will help us in becoming a better clinician also, more confident clinician also. Reading and question solving, you have to keep a balance, otherwise you will get confused in the exam hall. Follow the daily schedule. As I told you, this is really, really important because you don't want to pile up and then break down. You think now I cannot do anymore. So you have to be particular about your schedule. Time management, very important. Most of the time management is a problem. So utilize your workplace time wisely. Utilize your cooking time, utilize your driving time. Any ways you can take out time. If you are totally engrossed about your studies, if you are serious, you are focused, then definitely you can take out time. EMQ solving every day is very important, as I told you, because EMQs are the main problem for everybody. Practicing mocks help you in understanding that how you're performing in time-bound manner. Revision is very important. As we told, at least 3 to 4 revisions should be there. Practice, practice, and practice. Very important. Very important. As I always tell in my group, core students group, that practice here and make things wrong here so that you will not make that wrong in the exam. Making wrong here is the best thing because once you make it wrong, you will never make it wrong again. So making wrong is more beneficial while practicing so that you will not make wrong in the exam hall. So practice makes us perfect. Time management, as I told you, time management is very important because we all are committed with some or the other things. So we have to see how we can decrease our half an hour of sleep, how we can manage our time to do the things we have decided to do on that day. Question solving is important. Studying smart is important because if you'll do only study hard, like you will read all the talks, you will get lost. If you will not shorten your GTG nice, you will not make the notes, then you will lost at the end. So studying smart is very important. Question solving, especially EMQ, is very important. Without clear concept, making EMQ right is difficult. You have to have precise notes to revise it at the end. Now, how courses help? If you need help, how the courses run, courses will give you daily and monthly schedules so that way you can follow it. They give you notes. So definitely your hard work of making notes is not there because already my notes will become your notes. So it's easier for you. Material you get in advance, so you don't have to search the material here and there. Group study, you get a group of 20-30 students. We are teaching a small group. So group study means group discussion, and definitely it helps in retaining the things. One person doubt will help you making avoiding one wrong in the exam because that doubt can come in your mind later. So group study is always beneficial. It helps in 50% retention. Revision at your convenience because you can listen to the recording as many times as you want and you can revise as many times as you want because some module will be weaker for you than the other person. Every student need is different. So you can revise the weak module again and again. Balance of reading and question solving is very important. So you have to read every day. You have to solve question every day. Question answer sessions, we have even exclusive EMQ session. Recently, we have on CTG, detailed session of CTG as well as labor module EMQ sessions. So these sessions will help you in understanding how to read question, how to extract the right point and leave the distractors. Reading the question is really an art. If you don't read the question correctly, if you don't understand the question correctly, you will not be able to make a right answer. Mocks are very important. After every module, we have mocks. So accordingly, you can judge yourself how much you are retaining and remembering because mocks is having all the beautiful questions, all the exam-oriented questions. So that question quality really helps you in giving you real exam-like practice for that particular module. These are our some success story. If you see how they got benefited by recall sessions, by the group discussions, if you see how somebody prioritizing for you, telling you what is their most favorite, what you should focus more, that helps in your success. How the question solving, how the recording, summary of talks save your time too much and it will clear your concept to solve the questions. How your difficult things like difficult module like teaching ethics, clinical governance, which are very difficult for you, you will understand better and it will become clear for you. So these are our successful students' stories, which are telling us how the course helped them. This is our current batch feedback. So I'm very happy and delighted to share this, how they feel about the course, doing the question helpers, long guideline, you're making it very short, important concept. The pop quizzes, the daily quizzes running in our quiz group is really beneficial. So they are getting benefited by everything. They are getting benefited by the lectures. There is no queries after that. The slides are so easy and compact. So that is helping them. They can revise the recording again and again, and it makes them stronger every time they listen it. They are getting benefited by the question sessions, the module-wise discussion, how to read the questions, how to make the answers, how to exclude the option sometime. If you don't know the answer, you can even use exclusion method to solve the questions. So this is how the question solving in the EMQ sessions help us. And definitely you get the revision sessions. We are doing exclusively revision sessions. We are not like moving forward and forgetting what has been covered. So we do have every month revision session where we discuss what is covered previous month. So that way you are moving forward with confidence. So why to choose MMRCOG if you need help? Because we are doing small group teaching. We are giving a quality material in simplified manner and personalized solution for individual problem. Always the students are just a number away with me. They can always chat with me if they have any difficulty, any troubleshooting they need. They can contact me and they get the 24/7 assistance in all the groups. If some of my students are attending today, can they speak up? What is their satisfaction score with the course? How they feel and what is their review about the course? Any of my student here today attending, can you speak up? If anybody wants to speak up.
That this course simplify the things and especially point out what is important to study. So this is very nice in the course.
Thank you, dear Shazia. Thank you, my dear. Anyone
Ma'am,
else want to speak up?
your question solving and how to attempt the question is very good, and it gives us, way too confidence to handle to solve the questions. Plus, when you teaches us the focus points, you tell us how to exclude the things and what to read, what not to read, where to focus, where not to focus. It's wonderful.
Thank you, my dear Veena. Thank you so much. Even we had CTG solving in our group, which really helped the students to understand the real CTG scenario in my labor room. I'm posting in the group daily and they are answering it. So that way we really get a good practice of CTG, that what is happening in the real labor room. And we did practice the strategy questions of CTG. So that way we have covered everything about CTG and we are really feeling confident about that. Anybody else want to speak up?
Yes, about CTG and other things, I want to say that your way of making slides and making things simpler is excellent. Like how to, we cannot learn, this is a huge course, we cannot learn by heart each and everything. So how to simplify the bigger scenario into a small one, or a bigger chart or algorithm into a small bits and pieces and memorize it. That way I learned from you and it is terrific. I have improved a lot in it. Thank you so much for that.
Thank you, Dr. Yasmin. Thank you. I'm really touched by all your words. Really, this is what makes me going. Believe me, this is what the students' words are what make me going and help me in making better version of myself. So definitely, yes, I'm trying to help and all of you agree with me that There are students we couldn't make it even 1 time, 2 time, 3 time with a near misses. So please decide where you are lacking and change your strategy and take help if you need, so that we all can succeed and become a part of RCOG registration. So if you want to become the part of MRCOG family, we do have special offers for students who couldn't make it this time. So you can always contact me on this number. Okay, so let us start the study now. So we have done enough discussion and we have understood that how we are going to change our strategy, so make the difference next time. So we are going to read this guideline 2022 antenatal corticosteroid and the role of corticosteroid in improving neonatal outcome. This is 2021 talk. If you read both of this together, you get to know that the guideline is covering everything which is given in the talk. So here you don't need to read this talk. Only reading guideline is enough, because you might get 1 or 2 points from the talk, but whenever the GTG and talk both are there, you always have to rely on the GTG. If you see, there are some difference between the GTG and talk here, like the rescue dose. The talk say that you have to give in 14 days and GTG say you have to give in 7 days. So definitely you have to follow the GTG. So better not to read this and don't waste your time. So no need of reading this, only reading this is enough. And the remaining small tidbits and bits are covered in the session. So if you see what they say about antenatal corticosteroid. So antenatal corticosteroid is given within the 7 days prior to preterm birth. If it is given within the 7 days, then only it is beneficial. This is what the new concept they have got. Earlier, it was like we used to think that, okay, it's okay to give steroid. There is no harm, at least. If there will be benefit, but no harm. So now in this new GTG, they have focused and told about what could be the harm also with the steroid. So don't think that you can keep giving steroid, you can keep repeating the steroid. It is not a good idea. So give only when needed. Don't give just like that. Because if you give just like that, there are some side effects also. So they have changed the preterm guideline also. They have written that now you have to follow this in place of preterm guideline for the steroid. So this is a new change. This is definitely going to come in your exam, because this has come now. Your exam is in July, quite far. So definitely there will be question from this GTG. So it should be given within the 7 days prior to preterm birth. Means before birth, within 7 days only, if you have given, you will get the benefit. So what will be the benefit? The benefit will be reduction in perinatal death, reduction in neonatal death, reduction in respiratory distress syndrome, reduction, they say that there is moderate evidence that it will reduce intraventricular hemorrhage and developmental delay in childhood. So these are the risk ratio they have written. Risk ratio means 0.85 means the risk reduction will be 15%. You have to minus 1 minus 0.85 into 100. So the risk reduction, if they will ask how much percentage it will reduce 15%. So you have to do 1 minus and then calculate it by 100. Even in last previous recall, they have asked that how much it will reduce the respiratory distress syndrome risk. So you have to now write 29%. Earlier it was 44%. So now it has reduced to 29%. So here is the difference. The risk ratio has changed. The IVH is 0.58, means 42%. So this is the reduction. You have to understand it like that. Now, at what gestational age you have to give? Earlier it was 33 plus 6. Now it is 34 plus 6. So the change is 24 to 34 plus 6. So you have to understand this is a new change, and they have given only established preterm. This is a change. Earlier it was even for suspected and diagnosed preterm, you were giving it. But now they have told only for established preterm you have to give. Because as I told you, now they are focusing on what are the harms of steroid, how to avoid that. So you have to give in established preterm. You have to give in PPROM. You have to give in planned preterm. Planned preterm means definitely you can time and give your steroid. In cases of PPRN, you have to give, and only in established preterm you have to give. They say that benefit will be there if given before 24 weeks before also. So, but this you have to discuss with the consultant. So all that things will come here, that you have to consider this, but you will offer between 24 and 34 plus 6. Now, what will happen for the very late preterm? Now they have given here a new term. We know late preterm, which is 34 to 37 weeks. Now they have come up with a very late preterm with 35 to 36 plus 6 weeks. So 35 to 36 plus 6 weeks is very late preterm. So they say in very late preterm and before plan CS at 37 to 39 weeks, if you are giving, it may reduce the respiratory morbidity. So it may reduce. So keep it in mind that it may reduce and there could be some side effect also, which we will be seeing in the further slides. So if you see a risk and benefit, this is what they have recommended, that 22 you can consider and 24 to 34 plus 6 you have to give. So what will be the benefit? The benefit will be, we already saw, it will reduce the death, it will reduce the respiratory morbidity, and likely to reduce the intraventricular hemorrhage and developmental delay. So this is likely to reduce and this is highly likely to reduce. Now, what are the harms? If you are giving for a preterm, the harm could be that it can affect maternal glucose tolerance for up to 5 days. So maternal glucose tolerance for up to 5 days would be deranged. So if you are giving for a diabetic, the sugar can be uncontrolled for 5 days. So this you have to keep in mind. It can reduce the birth weight if birth more than 7 days. So if you have given a corticosteroid for a preterm and she delivers after 7 days, means the benefit is only till 7 days. So if she delivers after 7 days, there is a chance that there will be reduced birth weight. So this is bad, right? So this is not a good thing. So that's why they're telling that don't give it until unless you're sure that the delivery is going to happen within 7 days. So this is important, that you can have a low birth weight. You can have maternal glucose tolerance affected. You can have psychiatric behavioral changes if it is born at term. That means you are given for a preterm and now they delivered at term. So that could be a chance. So this is important. This is the harm with the steroid. Uncertainty, they say about multiple pregnancy, there is not enough evidence, so they are still uncertain, but you have to use a targeted approach for the multiple pregnancy as given in NICE and GTGs. Now, if you see all these benefits, you will see within 24 to 48 hours after starting the treatment. But after 48 hours, if the women will deliver after 48 hours till 7 days, the only benefit left will be respiratory distress reduction. These benefits will go. So this is important, that within 7 days, if she deliver, you will get only this benefit. Until 48 hours, you will get all the benefits. So all the benefit of especially the intraventricular hemorrhage, is specifically reduced only in the first 48 hours. So they might ask you that intraventricular hemorrhage will be, which of these will be reduced in first 48 hours only. After that, no more. So they might give you intraventricular hemorrhage because this is the maximum risk reduction. So if they give you all also, you have to choose intraventricular hemorrhage because that is the maximum risk reduction. So this is important. After 48 hours, only benefit is reduction in respiratory distress. So this is important. And there is no benefit after 7 days, even it is bad, even it can lead to side effects. Now, this is what they told about very late preterm and before plan CS, that it may reduce, likely to reduce respiratory support, may reduce admission to NNU with respiratory morbidity. So it may reduce the respiratory difficulty. But what are the harm? The harm will be neonatal hypoglycemia. If very late preterm you are giving, then there will be chance of neonatal hypoglycemia. There might be increased psychiatric and behavioral diagnosis. This psychiatric and behavioral, they have specifically told that it will be more for the term. So this is near term. So that's why these things are coming here. It may reduce educational attainment at school age. So all this behavioral, psychiatric, education, all these will be for term babies, not for the preterm babies, which you have chosen 34 to 34 weeks, 6 days. In that period, you will not get it. If you get it in very late preterm or plan CS, there will be psychiatric behavioral difficulty. And neonatal hypoglycemia also for very late preterm, not for the preterm where you have glucose tolerance problem in mother and small babies. So these are the things you have to keep in mind, that how it is different for different gestational age. The benefits as well as the harms are different. Now, What is the role of rescue course? We all must be knowing that rescue course is something very tricky. And if you see in the talk, they have written, according to ACOG 2017, it should be repeated in 2 weeks. But here now in new GTG, they have clearly written, if more than 7 days ago you have given, you can repeat it. But they don't say to repeat it. They say you can repeat it. Why they are saying like that? Because there is some side effect of that also. It is likely to reduce the respiratory support. Only the respiratory support will be beneficial. That is the only benefit you get. But there will be chances of reduced birth weight, reduced head circumference, reduced length, and reduced neonatal blood pressure. So this is very important, that if you keep giving the repeated doses, there are chances of having small babies, and there are chances of smaller head circumference, length, and BP. So that's why they say that please don't give steroid blindly now. Be thinkable, be cautious about what could be the side effect of that. So if you see the repeat dose, there will be no reduction in serious morbidity, means there will be no reduction in mortality or intraventricular hemorrhage or anything like that. No long-term benefits, but there could be smaller babies. There could be smaller length. So these are our concern. So how many maximum number of doses you can give? Maximum number of corticosteroid you can give is not exceed 3. It shouldn't be more than 3. So they say that even if you are repeating 2-3 times, like somebody came at 28 weeks with preterm labor, you gave, then she didn't deliver, she came again, then you gave, she didn't deliver, she came again. So if you have given like that, you cannot give more than 3. So 3 is the maximum. But they have written that WHO recommend only single rescue dose, so total 2 doses. So WHO recommend only 2, but the maximum number, if they ask you, you can give 3. So you have to keep the risk versus benefit versus risk in your mind whenever you are giving the repeat dose for a women. And you have to keep this different age group, how the harms are different. Now, if you see in different scenario, for cesarean section, we saw that it may reduce the admission. For multiple pregnancy, they told that you have to give offered only the targeted one. You don't have to give it routinely. You don't have to give the repeated doses for them. Only the targeted one you have to give. If needed, only you have to give. For diabetes, it is not a contraindication. It is not an absolute contraindication. You can give. Only you have to tell her to monitor her sugar and increase her dose of insulin. So this is what they say, that you can give, but keep a sugar evaluation up to 5 days, because it can be deranged up to 5 days. If you are planning CS, then there will be chances of neonatal hypoglycemia. We already saw that. Is small for gestational age preeclampsia APH? First of all, you have to see that you will not delay your delivery for steroid. You will give steroid, but if there is indication of delivery, you are not going to keep them just for steroid. Like APH, it could be dangerous for mother and baby. So you will do the CS if needed. You will do the delivery if needed. You will not wait for steroid to act. Severe preeclampsia, you will not wait for steroid to act. Severe SGA, you are not going to wait for it. But you can offer them this because there will be benefit of steroids. For PPROM, definitely you will offer, we already saw, it will reduce intraventricular hemorrhage and respiratory distress, but it doesn't increase the risk of chorioamnionitis and sepsis. What happened? If there is rupture of membrane, we are always concerned about infection. So we think that steroid might increase the risk of infection. So we are afraid about that. So you have to understand that there is no increased risk of that. So you can confidently give the steroid for lung maturity of the fetus. Clear? Am I clear about all this till now? Anybody has any questions? How the presentation makes a difference. If you see the slides, you'll get to know that how the presentation make it more catchy, more understandable. You can understand the things more, like it is 1 point, 2 point, 3 point. Accordingly, you can remember. So that way your impression and remembrance is much better by the presentation rather than reading the black and white guideline from the printouts or soft copies. So little color, little added color in your life is always good. Now, preparation and dose, what preparation you will take and how much dose you will give. So 24 milligram dexamethasone phosphate you will give IM. Dexa or betamethasone. Two things are available, dexamethasone phosphate or betamethasone sodium acetate mix. Sodium phosphate and acetate mix. Why the mixed? Because they say that half-life is longer. So you have to give total 24 milligram. How you will give? 2 divided doses, 12 milligram 24 hour apart. Or you can give DEXA in 4 divided doses. So there you will make the dose half and the duration also half. So 6 milligram 12 hour apart. So either 4 doses 6 milligram 12 hours or 2 doses 12 milligram 24 hours is what you have to give. If you are seeing betamethasone, only 2 divided doses, not 4 divided doses, because as I told you, the half-life is more for this mix. So you don't have to give 4 divided doses. It is not beneficial. So this is the difference in their dosing. Sometimes what they will give in SBA, they will write like that. They will change this 12 milligram 6 hourly, or they will give 6 milligram 12 hourly, 24 hourly. So like that, they will confuse you. So you should be really clear about the doses. This is a simpler thing. It is not a very hard thing, and we are doing it in our clinical practice. So please be careful about all the smaller things. Please be careful about easy things. This is easy. So never make easy thing wrong in the exam, because if you make one easy thing wrong, whatever with great difficulty and great hardship, whatever the difficult thing you have corrected, there will be no benefit of that, because that will become null and void. So never make easy thing wrong in the exam. That is the sole, the rule of getting a good score in the exam. Never make easy thing wrong. Try to make at least all easy correct. Then half of the job is already done. Because definitely in exam there will be some easy things. What is the benefit of dexamethasone over betamethasone? So it leads less intraventricular hemorrhage. It is slightly cheaper and it doesn't require refrigeration. That is the benefit. And what is the benefit of betamethasone over dexamethasone? Is it leads to less chorioamnionitis and it has a long half-life. So these are the differences between these two preparations. Now, what are the benefits? If within 24 hours also, if how they always say that you should give the steroid even if the time is not enough, even if you think the women will deliver sooner, at least give it. There will be some benefit at least. There will be some benefit of decreasing the mortality at least. So within 24 hours also it may benefit, so you will give. Within 48 hours, surely it will decrease the intraventricular hemorrhage, so you will give. And the maximum benefit of respiratory distress syndrome will be from 24 hours to 7 days of second dose. Mind here the second dose, not the first dose. So you are starting, you are giving after 24 hours and then after 24 hours means 48 hours from the first dose. So 24 hours to 7 days of second dose is the maximum benefit of respiratory distress syndrome reduction. So this is what you have to remember. This is where they will confuse you in the exam. This is how they will make the SBA from here. So these are the benefit. Then what are the risks? We saw the risk to the baby, neonatal hypoglycemia, less weight, less head circumference and length, and risk to the mother is deranged GTT. So these two things we saw for the mother and baby, as well as for the baby at term, psychiatric and behavioral problems. So this is what you have to memorize. Is there any contraindication of corticosteroid? This is a single dose. So we think that there is no contraindication. We saw in PPROM, there will be no chorioamnionitis, nothing, no problem. So is there actually any contraindication of corticosteroid? It is no. There is no contraindication as such, but you have to use with caution in cases of systemic infection, like sepsis, like systemic infection. You have to use with caution, but it is not an absolute contraindication of steroid. So this is all about this guideline, the small guideline, but very important one, and how the small things are critical in this. You have to memorize that. Anybody has any questions, or we can move forward to the talk. In courses, actually, we have, after finishing the guideline, we have a question answer session where we revise the take home messages. I ask some gross questions from the guideline, and at least that 10 points they are remembering forever. So that is how the impression become more stronger after each guideline. Clear, all of you? Shall we move forward? Okay, great. Now, this is a 2019 This is the 2019 talk, and very important talk because this is telling about long-term use of corticosteroid during pregnancy. So we have seen here a single mother who has come in labor or whatsoever, but we are now talking about somebody who is already on steroids. So what should you do differently in that cases? So if you see, there could be some condition like autoimmune diseases, allergies, asthma, dermatological problem, where you need to use the steroid throughout the pregnancy, right? So we all agree with this. In that scenario, you should be well versed about what changes you will do in the monitoring of the mother, as well as what you will do for the lung maturity. So for lung maturity, what preparation you will do? They might be taking prednisolone, they might be taking cortisol, but for lung maturity, you always have to use dexamethasone or betamethasone. This is also known as fluorinated corticosteroid. Why this one? Because they are not metabolizing at the placental level. Only 1.8% of dexa and 7.1% of betamethasone is metabolizing by the placental tissue, while 67% of cortisol and 51% of prednisolone is converted to inactive metabolite. You don't have to memorize this percentage. This is just for your knowledge that too much of this is already beaten up by the placental tissue enzymes. That's why if you are taking chronically these agents, this is not going to be enough for the lung maturity. So if a woman is taking chronically a steroid, come to you in preterm labor, you will be giving them the steroids. A standard course of dexa or betamethasone for lung maturation is recommended. This is a very famous question and you should remember it well. Now, if you see the properties of steroid, this I just put for you to understand a bit about what are the different agent and how it is different. So if you see cortisol is short acting, prednisone is intermediate acting, and dexa and betamethasone are long acting. So if you see the maternal fetal ratio here, too much of maternal but little fetal. Only one fetus and 8 to 10 in mother. Here, if you see 2 in mother and 1 in fetus. So it is almost 50% going. Here, 33% is going. So very beneficial. Placental transfer is good for dexa and betamethasone. Now, what about if the woman is taking on systemic chronic corticosteroid? What all precautions you will do? All corticosteroid cross the placenta, but fluorinated are better ones, so we are using them for lung maturity. They say that there is conflicting evidence of teratogenesis, but there might be increased prevalence of orofacial cleft. So they recommend that you should do a detailed anomaly scan for the mother. So you are expecting this. So you will be doing the detailed scan. There could be growth restriction, as we saw that if we are taking rescue doses also, or she's delivering after 7 days, there are chances of SGA baby. So growth restriction is a possible thing. So you will be monitoring for the growth restriction. There will be derange GTT, so you will be monitoring for the screening for the gestational diabetes. You will be giving stress doses according to the need. Individualized means according to the need you will give. There is no adverse effect to the breastfeed infant, so the mother can breastfeed the baby. The corticosteroid are not a contraindication for breastfeeding. You will give additional corticosteroid if she comes in preterm labor. There will be some drug interaction, like she cannot use mifepristone with corticosteroid, so you will not give mifepristone for abortion and for IUFD. These are the true scenario where you use mifepristone, so you will not use that. And there are drug interaction with estrogen, that estrogen increase the steroid. So if you are taking oral, supposedly if the woman is taking oral contraceptive pill, she's not pregnant, she's taking oral contraceptive pill, then the steroid level could be more. So estrogen will increase the serum concentration of steroid, so you have to be careful about that. So these two are the drug interaction with mifepristone and OC pills. Now, what will be the peripartum management? Peripartum, will you give stress dose for all? So they told no, only you have to individualize. So you will be giving stress dose for all for people with Addison's disease, because there is adrenocortical failure. So you will give stress dose for all. But other conditions, they say that there is dilemma, should you give, should you not give the stress dose? So you have to determine it by the pre-operative doses, duration, what was the nature, duration, all these things. How long she has taken, what dose she's taking, accordingly what agent she's taking, accordingly it will be individualized. But Addison's disease, you have to give the stress doses either labor or cesarean in both the scenario to prevent the vascular collapse. So the stress dose question is also common, that if a woman is taking the steroids, you have to give them stress dose during labor. Now, how you will monitor? You will monitor, as I told you, you will do the anomaly scan, you will monitor for growth, you will do the diabetic screening. In peripartum, she might need stress dose. In preterm labor, she might need the DEXA cover, and you will not give mifepristone to her. In postpartum, you will give the pediatric neonatal evaluation, because if the mother is taking the steroid, baby could be affected, baby could have cleft, baby could be SGA, so it needs the pediatric evaluation. So what's specific about the breastfeeding? Will there be completely safe, or you will do any changes in the practice? This is also an important recall question. So safety in breastfeeding, they say that there is no adverse effect, but they say that to reduce exposure, you should use prednisolone instead of prednisone. So if she's taking prednisone, you will change it to prednisolone, and you will avoid breastfeeding for 4 hours after a dose. So this is an important fact, that it's okay to avoid 4 hours. She can express the breast milk and then or feed the baby, and then she will take her prednisolone dose, and then after 4 hours she will again feed. So this is a precaution you will take, but it is not contraindicated. There is no adverse effect on the breastfeeding as such by mother taking the steroid. For breastfeeding, there is a beautiful talk article about breastfeeding and drugs. And you have to understand, in breastfeeding, only a minimal amount, only 1%, 0.1% of the drug is going in the breast milk. So how much it will affect the baby? So most of the time, the drugs are safe. Only some particular drugs are there where they say that you cannot use it at all. So be very careful about, like lithium. They say that with lithium, you cannot breastfeed. Like amiodarone, they say you cannot breastfeed. So all these things you have to keep in mind. Breastfeeding and drug is very important talk article, and it is very favorite of RCOG. You should always learn well about the drugs. Okay, so this is all about our teaching and learning. Now we will do the question practice. Yes, so anybody interested in reading can read the first question.
Yeah,
Can
a
I read?
32-year-old woman,
Yeah, it's okay. Go
a
ahead, my dear.
32, yeah, a 32-year-old woman at 32 weeks of gestation came in established preterm labor. All of the following risks can be reduced by giving antenatal corticosteroids, except neonatal death, yes. Psychiatric and behavioral changes, no. Respiratory distress, yes. Intraventricular hemorrhage, yes. The answer will be B.
Very good, my dear. Very good. So it is clear to you that this can be increased in the term babies. So this will be increase rather than decrease, and all other three definitely will decrease. Very good. Yes. Next question. Yes, Yasmin, you can go ahead.
A 28 years old primary gravida came at 30 weeks of gestation with PPROM and received antenatal corticosteroids. She again presented at 33 weeks of gestation in established labor and delivered vaginally. Which of the following are the risk? So she received twice.
She received only
Neonatal
once. She received only once, Yasmin, because she received antenatal steroid at 30 weeks and she delivered at 33 weeks. She again presented at 33 weeks, but you have not given her again.
Okay. She received once, sorry. So number one is neonatal hypoglycemia, deranged GTT for mother, SGA, and psychiatric and behavioral changes.
So what do you think?
So at 30 weeks of gestation with PPROM and received antenatal corticosteroids. 30 weeks is the late one, but not too late. So
33 week is not a late one. From 34 weeks is late preterm. From 35 weeks is very late preterm. So 33 weeks is preterm. Yes, go ahead. You are going right. Come on, go ahead.
33, and at 33 she delivered. So she delivered after 3 weeks.
Very good. So you got all the point from question. Now you have to, this is the most tricky question I feel, and I'm very proud of making this question actually. So what do you think? You have to rule out. Now you don't know what is the answer, right? So let us rule out. Neonatal hypoglycemia, when it happens? You remember the chart?
When the mother is especially diabetic
And
she receives corticosteroids, then the baby
no,
the
when
baby
she
might
received
have.
corticosteroid that lead to neonatal hypoglycemia. What they mentioned in the chart.
Actually, I was busy at that time, so I
No
don't
problem.
remember. I'm
So let us
mixing the
go
things.
back to that chart. So here is the chart. Neonatal hypoglycemia when it is very late preterm. Now our baby is 33 weeks, delivering at 33 weeks.
No, it
We
is
gave
not very
at
late.
30 weeks. So neonatal hypoglycemia will not be a risk because it is for very late preterm, right? Then the
Yeah.
other thing is the psychiatric behavioral changes. Psychiatric behavioral changes, they always told that it will be for the term. If the baby is born at the term, you have given them steroid and their baby deliver at term. So your baby is delivering at 33 weeks. So psychiatric behavioral changes is for term. When either or here they have written, which is very late preterm. So neonatal hypoglycemia and psychiatric behavioral changes will be for very late preterm. Keep it like that. Or for term, this one. So both these things are not correct because your baby is delivering at 33 weeks. So now what is left? Deranged GTT and SGA. So deranged GTT
SGA.
is only for first 5 days. And your
Yeah,
baby is delivering after 3 weeks. So deranged GTT time is over now,
yeah.
right?
So
You are left with,
SGA will be there.
yes. So this is how they make the questions from the chart, how they complicate your and play with your mind, play with words, all every chart, every important information highlighted in the guidelines and talks are important to memorize. So here the answer will go SGA because this is for first 5 days and it is 3 weeks now. This is for very late preterm or very late preterm and this is for very late preterm or term and your baby is still preterm. So this is the only risk left to choose in this questions. Very good, my dear. Thank you. Yes,
Thank
next
you.
who will read?
I will read, doctor.
Yes, go ahead, my dear.
Antenatal corticosteroid should be offered at what gestational age? From 24 to 34 weeks sick days.
Yes, very good. So now because we have freshly read, we remember it. But in exam, what happens sometimes they will give you 20. They have given here 22. In the chart, they have written you can give from 22. But they have asked the word
Should be
offered, right? So offered means from 24 you have to choose. You will not choose from 22. Because from 22 to 24 you have to discuss. So this is how they confuse you in exam. Either they will change the first value or change the second value. So you have to be very particular about word, what word written in the question, as well as the options very carefully you have to read and choose. So the answer is C. Very good, my dear. Now, yes, who wants to read this?
Ma'am, I
Anyone
will
can
read.
read? Yes, go ahead, my dear.
A 25-year-old multigravida with previous history of preterm delivery came in established preterm labor and received antenatal corticosteroids and delivered after 12 hours of second dose. When would be the maximum benefit of antenatal steroids will be seen for the fetus? After 48 hours of first dose.
Very
Option
good.
D.
Very good, my dear. So this is after first dose. So if you don't note the detail of first dose, second dose, you might make the mistake of remembering like 24 hours after the first dose. So you have to remember that line very well that it is 24 hours after the second dose. Here they have given you second dose. Now because you have just read the guideline, just read and just solving the question, it's easier. But in exam, you might get confused. It was second dose or first dose. So always keep clarity in your mind about this confusing point, which can confuse you in exam. Give an extra attention to that. Give an extra time for that point to remember in your mind and keep it separately in your mind so that you will never get confused in exam. Because in exam, we are under tension. We have to produce under pressure. So sometimes even what we are remembering, we keep forgetting. So you should do your preparation the way that you will never get confused about silly things. So that will definitely help you in short success. So key is D. Yes, this is the last one. Who want to read?
Hello, ma'am. Good evening, ma'am. I want to read.
Yeah, go ahead, my dear. What's your name?
Ma'am, I'm Aditi.
Yes, Aditi, go ahead, my dear.
A 34-year-old woman is on 40 mg prednisone for SLE. The following is correct regarding her management, except A. GDM screening should be offered. B. Detailed screen for fetal anomaly. C. Monitor fetal growth. D. Breastfeeding is contraindicated. Ma'am, the answer should be D because they're asking correct except. Ma'am, GDM screening should be offered and fetal anomaly screening should be offered and fetal growth monitoring should be done. So it's safe breastfeeding.
Very good, my dear. Why some of you chose B? Can you speak up? Whoever chose B, can you speak up? What is the anomaly you can see with prednisone in SLE, my dear Aditi? What anomaly you can see?
Orofacial defects can be
Yes,
seen in
orofacial cleft defect can be. Read except later. Very good, Shilpa. Very good, my dear. So this is what I'm telling. Half of the art of succeeding in exam is reading exam. And even if you have read the except or not, if you are clear about you have to do the screening, you have to monitor the growth, how you will not understand reading by reading the question also that three are correct. Then if you are thorough with your preparation, once you read the answers, you have not read the except in the question. Okay. Now you'll go to the answer. If you remember the talk well, you will understand that these three are already there. So then you will go back to question and you will search for the word except. But the good thing is to read the question carefully. You don't want these silly things to happen with you in exam. Always the words like except, the word like most important step, most appropriate management, next step, next management, very important. Very important for you to read the initial instruction of EMQ that what they're asking you. Is it a next step? Is it a most important step? Because that will be different. Next step could be CBC, doing the CBC. But most appropriate step could be Mirana. So that is the difference. If you don't understand the difference of next and most appropriate, most of the time you will get confused in exam. If you don't read the question correctly, that's why we have the exclusive EMQ session. That's why I judge every student at that time that what is their weak point so that I can help them personally at their weaknesses. See, I'm not that kind of person who will give everything in the beginning that this is your library, here everything you have, now go with this, go with your preparation. I always give time bound things. I always give that in 2 days you finish this one, then next days after we will finish the module, you keep one day for mock, like that. So that way you are doing in an organized way the preparation, not like haphazardly what to do now, what to do next, like that. So as I told you, take one day at a time and follow your schedule and it will do wonder for you. So key is D, breastfeeding is contraindicated. Sometimes you will get confused by prednisone because we saw that prednisone should be converted to prednisolone. But that doesn't mean that with prednisone you cannot breastfeed. That will be a preferred one because now it's clear because just now you read. Why I'm telling you all this confusion you'll get later because this is how the students get confused. This is what I have seen, how they get confused. So these all are the small points which gives you confusion at the end in exam. So be very careful in reading, be very careful in understanding and keeping your concept clear in your mind. And as I always tell that do it always module by study and organized study. These are all our free groups, MRCOG, Facebook group, Telegram group, and YouTube. In YouTube, you do have some recording of important talks and GTGs. In Telegram, we do have daily question answer discussion of module wise. And in Facebook, we do run the schedule as well as the important announcement. So this will definitely help in your preparation. If you want to join and you're not part of it, you can join it. Anybody has any question? Anyone want to ask anything regarding any difficulty they are facing while preparing or anything? Nothing? You all are having all the clues, all the tips and tricks of how to handle things, how to handle the stress well. Okay, good. So I will take it as a compliment that you are clear now. So as I tell that quality isn't expensive, it's priceless. You should have a dedicated learner, dedicated mentor, learning good and learning environment and good content, good prioritization. Then only you can have a quality education. So if you're waiting for the right time, it's now. So let's start from now. Still we have 140 days left for the exam. That is enough. That is enough for us to prepare for pass. If you are giving it for the first time or even for the second time or whatsoever. For my course students, my advice is take maximum benefit of course. Take part in everything, participate in everything and take maximum benefit because that will definitely make a difference. So all the best to you all and thank you all for attending the session today. And soon the recording will be uploaded in the YouTube. Thank you all.
Thank you, ma'am.
Thank you, Dr.
Thank you. Thank you.